Good afternoon. Great pleasure to be with everybody today. Welcome to Recent Advances in Cancer Care, New Paradigms, New Agents, and What It Means for the Oncology Nurse here at the 51st Annual ONS Congress. So here are our great faculty for today. A great pleasure and thanks to the team at Research to Practice for inviting us. My name is Seth Wander from Boston, and I'll be moderating. I'd like to introduce our faculty. We have Dr. Reva Basho from Los Angeles, Ms. Kelly Fischer from Boston, and Ms. Melissa Rikal from Nashville. So we have all over the country represented up here today. Here are our disclosures. So this activity is supported by educational grants, and we would like to thank all of our supporters for today. The Research to Practice Planning Committee members, staff, and reviewers have no relevant financial relationships to disclose. And this educational activity will contain discussion of non-FDA-approved uses of agents and regimens. Please refer to official prescribing information for each product for approved indications. We're going to be talking about new agents, new therapies. We're going to focus today on when they should be used, for which patients, and why. We're going to be focusing on side effects. Throughout the presentation, we'll be reviewing clinical data, and we'll try to put that into the context of real clinical cases. We're going to show you data like this, Kaplan-Meier curves and waterfall plots, and we're going to review why these are important throughout the session. Just to kind of set the stage right now, when we show these Kaplan-Meier plots on a prospective clinical trial, we're showing you progression events. So every time the curve drops down, that's another progression event that's been logged. And so really what we're looking at here are the separation between the curves. This is the rate of progression between two different groups of patients. And the farther apart the curves are, the more benefit we're seeing as it moves over and farther to the right. The more the curve pulls over to the right, the longer it takes to see progression, the better the clinical outcome. And on the bottom, we're showing you these waterfall plots, and we'll see some of these throughout the session today. These waterfall plots are each showing you for an individual patient what's the depth of their response, how much of a reduction in tumor burden are we seeing, for example, on a scan. So the deeper the waterfall plot goes below the middle line, the better the response in each individual patient. Okay, so here we go. We're going to get started. We're going to cover a lot of really exciting topics on PI3K, AKT, mTOR. We're going to talk about targeting this PI3K, mTOR pathway in hormone receptor positive metastatic breast cancer. And this is going to be our agenda. We'll start by looking at identifying appropriate candidates for agents targeting this really important pathway in metastatic breast cancer. We'll talk about the role of Inavolisib in metastatic hormone receptor positive breast cancer. And throughout the session, we're going to be focusing on management of a number of common toxicities that have big impacts on patient care and quality of life. We'll talk about preventing and managing hyperglycemia. We'll talk about an AKT inhibitor, Capivasertib. We'll talk about management of GI-related and dermatologic side effects. And then we'll talk about one of the newest drugs to come onto the block here, a drug called Gedatolisib, which is a pan-PI3K, AKT, mTOR inhibitor. And then we'll end by talking about management of cytopenias. Okay, so we're going to start with introduction and identification of appropriate candidates for agents targeting this pathway, and I'll turn it over to Reva.
Thank you so much for having me today. So I'm going to start by setting the stage of the PI3 kinase pathway in hormone receptor positive breast cancer. So the PI3 kinase AKT pathway is an intracellular pathway that results in cell proliferation and growth. It is one of the most frequently activated pathways in hormone receptor positive breast cancer, which is why it has been such an interesting target for drug development. There are several points of interest of this pathway that are particularly interesting for drug development. So upstream, there's PI3 kinase. PI3 kinase consists of two subunits, as you can see on the right, the P110 catalytic unit and the P85 regulatory unit. And this is important because the P110 catalytic unit is encoded by the gene PIK3CA. So PIK3CA is the most frequently mutated gene in hormone receptor positive breast cancer, with mutations seen in about 40% of patients. So when we talk about alpha-specific inhibitors of PI3 kinase, you'll hear this term throughout the talk today. We're really talking about inhibitors that target that P110 catalytic subunit of PI3 kinase that's encoded by the PIK3CA gene. More downstream, we have AKT. AKT is a central node of this pathway that regulates downstream activity. And we also have agents that target the pathway at AKT. Mutations in AKT itself, though, are rare, seen only in about 1% to 2% of hormone receptor positive tumors. And then more downstream, we have mTOR. mTOR is the regulator of downstream transcriptional activity of the pathway. So why are mutations in this pathway important? We have seen across large studies and large meta-analyses that mutations in this pathway lead to worse outcomes. So here's some examples here. SAPHIR-02 was a large study in breast cancer looking at genomically targeted therapy, and the study showed that in patients who had a PIK3CA mutation, there were worse outcomes shown by the Kaplan-Meier curves, so that the curves were shifted to the left. And on the right, we see a meta-analysis of published trials, again showing that patients whose tumors had mutations in PIK3CA across trials of hormone receptor positive metastatic breast cancer had worse outcomes with plots to the left on that curve. So today, when we treat hormone receptor positive advanced breast cancer in the frontline setting, our standard therapy for patients is a combination of aromatase inhibition plus CDK4/6 inhibition, supported by 3 large randomized phase 3 studies of various CDK4/6 inhibitors that demonstrated a consistent and statistically significant improvement in median progression-free survival when CDK4/6 inhibitors were added to aromatase inhibition in the frontline setting. So what happens to those patients who have PIK3CA mutations when they get our standard therapies? So on the left is the MONALEESA-2 study. This was the study that looked at the combination of letrozole and ribociclib in the frontline setting. And you can see that those patients who had PIK3CA mutation, the yellow curves compared to those who were PIK3CA wild type, had worse outcomes whether they were in the control arm or the CDK4/6 treated arm. So even with our contemporary frontline treatment for patients, those patients who have a PIK3CA mutation have worse outcomes with our standard therapy. On the right, similar outcomes. This is the MAINTAIN study. So this was a second-line study looking at CDK4/6 inhibition in the second-line setting after progression on CDK4/6 up front. And again, we see that those patients who had a PIK3CA mutation, the curve on the bottom, did not derive benefit from continued CDK4/6 inhibition compared to those who did not, on the top, had better outcomes with CDK4/6 inhibition. So we see that our standard therapy today, those patients who have a PIK3CA mutation have worse outcomes. So that's really what's led to a lot of drug development in this space, a quest to target this pathway and improve outcomes for these patients. So today, what we typically do is those patients who progress on frontline AI and CDK4/6 inhibition, we do next-generation sequencing of their tumors or of blood to look for potential mutations that we can target. And one of the primary pathways that we look for those mutations is the PI3 kinase pathway, because if we can identify those mutations, we can think about targeted drugs. So what happens to PIK3CA mutations through the course of disease? This is really important because it drives when should we look for these mutations. What we know about PIK3CA mutations is that they are truncal mutations. What does that mean? These are mutations that develop early in the course of disease and are present throughout the course of disease. So for the most part, our PIK3CA mutations are going to be there at the time of metastatic disease, and they're going to stay consistent through the course of disease. So that means whether we get the NGS testing or the sequencing early or later in the course of disease, we should see these mutations. And you can see that in the Mona Lisa 2 study. So these were patients, they underwent biopsy at the beginning of the trial and at the end of the trial. And for the most part, you can see the red and the yellow at the top, those mutations in PIK3CA were consistent through those 2 biopsies. So through the course of the disease, we could find those mutations. But then there were a small number of patients who picked up mutations as treatment went on. So they didn't have them at the beginning, or they weren't found at the beginning. And as they were treated with CDK4/6 inhibition, they acquired those mutations. So this is important because we may want to look for those mutations early because they stay consistent, but there's a small number that are going to acquire those mutations, so we may want to look for them in real time when we're making decisions about treatment. And that really drives our quest for thinking about how are we triggering these, the next-gen sequencing, and when are we triggering the next-gen sequencing? So there's 2 ways that we can send off samples for sequencing. We can send off tissue from the tumor itself. So if we do a biopsy, we can send that tumor tissue. Or we can send off blood. And there's pros and cons to each. So when we have a biopsy, typically at the time of metastatic diagnosis, we can send that off. And if for those PIK3CA mutations that are going to be present throughout, we might find them at that time. But getting a biopsy every time we're making a decision about treatment is very invasive. And so we might send off liquid biopsies or blood samples at the times when we're making decisions about treatment, so when we approach second-line therapy. And one of the greatest benefits of liquid biopsy, of blood biopsy, is that it gives us a comprehensive picture of all the metastatic sites. So if some of those sites acquired a mutation that led to activation of the pathway, but others didn't, if we did a tumor biopsy at the wrong site, we may not capture it. But with a liquid biopsy, we might be able to get a full comprehensive picture of what's happening. And why is this important? It's important because targeted treatments are rapidly increasing in breast cancer. So this is a map of the last few decades. And you can see just in the last few years, the number of FDA approvals of targeted therapies that we've had in breast cancer is skyrocketing, and that trend is going to continue. And many of these drugs, the ones in yellow stars, target the PI3 kinase pathway. And again, this trend is going to continue as well. So it's important to identify these mutations to be able to select the right drugs.
Great. Thank you, Reva, for the great overview. Let's chat now about Inavolisib. So this is a specific PI3 kinase inhibitor that was relatively recently deployed in hormone receptor positive metastatic breast cancer. And then we'll circle back, I think, to cases and discussion after this one. So here, just coming back to the idea of PI3 kinase as a key oncogenic driver for metastatic breast cancer, what I'm showing you here are the different areas where some of the drugs have been under active clinical development. This is a structural diagram of PI3 kinase, and you can see the drugs that we're going to talk about for now are non-mutant selective, meaning they bind the abnormal PI3 kinase inside of the cancer cells, but they also bind the normal PI3 kinase in other tissues. And that's why you see a lot of the toxicity that we're going to review later on, hyperglycemia, diarrhea, etc. We have some mutant selective drugs that are under active late-phase clinical development that are specifically designed only to affect the mutant type of the protein. And then we also have some downstream inhibitors, and we're going to learn about those as well. AKT inhibitors, mTOR inhibitors, etc. So this is just another diagram. This is from a nice review that one of our fantastic fellows wrote a couple of years ago, showing the different resistance mechanisms to hormone therapy and CDK blockade. And you can see some of these pathways, the RAS pathway, the PI3K. These are well-known pathways that drive tumor growth and progression, that provoke resistance to things like tamoxifen and letrozole and palbociclib and ribociclib. And here I'm showing you a simplified overview. PI3 kinase activates AKT, activates mTOR, drives all the bad things that tumor cells need to survive: growth, survival, motility, metastasis. And in red, I'm showing you the different drugs that we're going to start to talk about throughout the course of today. And right now, I'm going to focus first on the PI3K inhibitors, Alpelisib and Inavolisib. This is the SOLAR-1 study. So this was published in 2019. These patients had progressed on an aromatase inhibitor, typically letrozole or anastrozole. There was not a lot of use of CDK inhibitors at the time that this study was enrolling, so very few of them had a CDK inhibitor. They were randomized to fulvestrant, injectable fulvestrant alone, or fulvestrant with this PI3 kinase inhibitor, Alpelisib. There was a cohort without PIK3CA mutations, and there was a cohort with PIK3CA mutations. And here are those curves. That's the progression-free survival, as we were talking about a few minutes ago. And just on the top right, I'm showing you, not terribly surprising, but the patients who didn't have the mutation, the patients who had no abnormality in PIK3CA, they didn't really get any benefit. You can see those lines are pretty close together. But on the bottom there, the patients who had the mutation, when you target that mutation and block the pathway, you see the curves begin to separate, and the time to progression improved from about 6 months up to 11 months. And this corresponds to a hazard ratio of 0.65. Another way to think about this is it's about a 35% improvement in the number of patients who are progressing at any given time, okay? And here's the overall survival. So here you can see in terms of overall, not just progression-free, but overall survival, there's a trend in the right direction. The patients who are getting Alpelisib are doing better from about 31 months to 39 months, but it didn't meet statistical significance. So it was there, but it didn't meet its primary endpoint. And these drugs are significant toxicity that we can run into, and we're going to chat a lot about this over the next little while. Here you can see some of the main side effects in the SOLAR-1 study. The discontinuation rate, the number of patients who had to stop this drug on the trial, was quite high, 25%, 1 in 4 patients. And you can see, just looking at the table, really high rates of hyperglycemia, including a third of patients who had high-grade hyperglycemia. And another 2/3 of patients who had low-grade, grade 1 to 2 hyperglycemia. So almost everybody had some degree of hyperglycemia in this original study. There was also mostly low-grade diarrhea, nausea, fatigue, rash, stomatitis. And so this drug had clinical benefit, but there were significant challenges when the drug moved into clinical practice. Now, here's the INAVO120 study. This is the second PI3 kinase inhibitor, and this is a more recent study published in 2024. Now, this is a different population. The SOLAR-1 population, they all had aromatase inhibitor in the metastatic setting, and then in the second-line setting went on. These are patients who had adjuvant, so they had early-stage disease. They were getting usually letrozole, anastrozole, or tamoxifen, and on adjuvant therapy, or within a year of stopping adjuvant therapy, they had metastatic progression. So these are particularly difficult to treat cases because they already had some endocrine therapy and they're still progressing through it. So if these patients had a PIK3CA mutation and an A1C of less than 6%, they were randomized to get palbociclib with fulvestrant, doublet, or palbo and fulvestrant with Inavolisib, which was the second PI3 kinase inhibitor. And here again, you can see these curves are pulling apart nicely. The yellow curve is moving up and to the right. We had a median progression-free survival improvement from 7.5 months to over 17 months. So the hazard ratio there was below 0.5, more than a 50% improvement in the likelihood of progression here. So really clinically significant, highly significant p-value. We also have positive overall survival data. You can see that yellow curve again with the triplet Inavolisib moving up and to the right. Improvement in overall survival from 27 to 34 months, which met statistical significance, unlike the study that I showed you previously. And here's the tox table. Now look at the discontinuation rate here. 25% with Alpelisib, 7% with Inavolisib. Now, I'll ask my colleagues in a minute what their thoughts are on this. My opinion here is that this is a combination of the drug may be less toxic. It's sort of a newer drug that we've understood the therapeutic window here. Also because as clinicians, nurses, nurse practitioners, MDs, we know what the side effects are likely to be. We're getting better at anticipating them and preventing them, and so the discontinuation rates are lower. Here you can see high-grade cytopenias, but that's really because of the palbociclib that's being given here. You can see the stomatitis rate is still over 50%, but it's mostly low-grade. And hyperglycemia, look, the high-grade rate dropped from 33% to 6%, so really significantly less high-grade hyperglycemia. We still see low-grade GI toxicity and rash, all of the things we expect. And this is what I'm showing you here. So I think it's really hard to throw these big tables up and look at all the different numbers on the table. So what we've done here is we're going to look through all these studies tonight. But I want to show you just the left-hand side, alpelisib and inavolisib. These are the two that we've talked about so far. What I'm showing you here are the 4 drugs that are either in clinical practice or about to be in clinical practice. And I'm showing you all grade and high grade toxicities that we tend to run into the most in clinic: hyperglycemia, diarrhea, mucositis, and rash. And in gray, I'm showing you the winner, the drug that had the lowest rates. So you can see alpelisib, unfortunately, didn't win any of that, right? That was the most toxic of all of these drugs. With inavolisib, we're moving in the right direction. Look at the reduction in the high-grade toxicities. And inavolisib, of all 4 of the drugs we're going to learn about today, actually had the lowest rates of rash across the board. We're going to talk about Capivasertib and Gedatolisib in a few minutes. And I just want to draw your attention to some newer studies that are ongoing right now that could reshape the landscape. So right now, inavolisib is only approved and used in those patients who meet that criteria. They had early stage disease, endocrine therapy, and they're progressing on endocrine therapy with a PI3K inhibitor. This is the Inova 123 study. So this study is all frontline patients. It doesn't matter if they previously had early stage disease with growth. So these patients could have never had prior endocrine therapy or could have had endocrine therapy 5, 10, 20 years ago. They have metastatic disease, so this is kind of an all-comer frontline population. They have to be PI3K mutant. They're getting letrozole with a CDK inhibitor or letrozole CDK inhibitor with inavolisib. If this study is positive, it would mean everybody needs testing in the frontline setting, and the 40% of women who have PI3K would potentially have access to this drug. So it would be a big game changer. Okay, so we have a couple of discussion questions here to chat about. And the first is, for which patients are you prioritizing use of the triplet regimen? And I'm going to go to Reva first on this. So for which patients are you prioritizing the triplet regimen of inavolisib, palbo, fulvestrant in the frontline setting?
Yeah, it's challenging because Inova 120 is a really exciting study because not only was the hazard ratio less than 0.5, really showing a significant benefit of adding inavolisib to fulvestrant and a CDK4/6 inhibitor, but also the overall survival was improved. So the magnitude of benefit is very promising. The design of the trial happened before CDK4/6 inhibitors routinely entered into the adjuvant setting. So today, for our high-risk breast cancer patients, we give them a combination of an AI and CDK4/6 inhibition in the adjuvant setting. And Inova 120 really looked at those patients who progressed on endocrine therapy in the adjuvant setting, so limited, no prior exposure of CDK4/6 inhibition. So time will tell what the magnitude of benefit is in patients who have been pre-exposed to CDK4/6 inhibition. But when I contextualize this into my patients today, I really think of this regimen as those patients who I start adjuvant therapy in. So they're very high-risk patients. They got chemotherapy up front. They get a CDK4/6 inhibitor and an aromatase inhibitor in the adjuvant setting, and they progress on adjuvant therapy, and they have a PI3K mutation. I've identified these patients as very high risk, and if I can identify the mutation in those patients, I would reach for the triplet regimen.
Great, thank you. So Kelly, I just wanted to ask you about your thoughts in practice, seeing a lot of patients. What have you seen with this drug? What kind of side effects? Does it match what I showed for the tox table?
It definitely matches. So as far as with side effects of the Inavolisib in clinical practice, what we're seeing is cytopenias. So patients can have anemia, thrombocytopenia, anemia. And it's important to remember that this is usually paired with palbociclib, which can also cause a high rate of neutropenia. So I think that the numbers sometimes will be a little bit hyperinflated, but that's because it's paired with palbociclib. So we definitely see a lot of cytopenias. We see some GI effects like diarrhea, nausea, vomiting, and stomatitis. We can see hyperglycemia, we can see rash, fatigue. So all of those side effects are what we're seeing in real life. And certainly as nurses and as nurse practitioners, it's our job to really educate patients on what to expect and make sure they have a lot of tools in their toolbox at home to make sure they're able to manage these at home.
Thanks. Yeah, and Melissa, I'm curious, in your clinical practice, what are you warning these patients about, not just about the side effects, but when should they call, what's the threshold to call, and just big picture, I know we're going to get into the details as we get through the modules, what are some of the things for the triplet that you guys are giving patients preemptively or to have on hand?
Yeah, I think like Kelly said, just the more these patients can have in their toolbox and the more they can be prepared going into this. So we know we can see diarrhea. Go ahead and have some loperamide on hand at home. With that first episode of diarrhea, you'll have it there. You can take it. If it becomes uncontrolled, where you're taking up to 8 tablets a day and you're not sure what to do next, obviously we need to be notified at that point. Talking through the stomatitis risk, lowering your intake of high acidity foods, improving your oral hygiene with a more sensitive toothpaste, sensitive toothbrush, those sorts of things. And then talking through the potential for rash. Although we do see less rash with Inavolisib, we know we can see it. So a lot of our patients will start an antihistamine, a non-drowsy histamine at the beginning. So kind of having that cetirizine on hand along with the loperamide to go ahead and use those prevention strategies on the front end, the way they can tolerate it better for longer, that good durable benefit.
Great, thanks. That's a great preview for what we're going to cover over the next 40 minutes or so in more detail. Okay, so let's move on to that. So you'll see, as I laid out at the beginning, the review of the clinical data is going to be interspersed with sort of a deep dive on management for some of the toxicity that spans the entire spectrum of these drugs. So let's go now to addressing hyperglycemia, and Melissa, take it away.
Okay. All right, hyperglycemia. I know when we first started having the PI3 kinase inhibitors in our clinic, especially with Alpelisib coming out, this was an anxiety-provoking AE to see hyperglycemia, not knowing how to manage it. So I love educating on this and helping people feel comfortable when they see this occur. So essentially, why do we have hyperglycemia with this pathway? The inhibition of the PI3 AKT mTOR pathway impairs insulin signaling. This causes decreased glucose uptake in our muscles and adipose tissue. And then we have increased hepatic glucose production, which leads to an elevated blood glucose. Some of the risk factors we're looking for when a patient is starting one of these agents, where we know we may have a heightened risk of seeing that hyperglycemia. Patients with pre-existing type 2 diabetes or pre-diabetes going into this, that obese patient with a higher BMI has known higher insulin resistance, advanced age, family history of diabetes, and a sedentary lifestyle. Some treatment-related risk factors we can see would be patients that are using a more potent PI3 kinase inhibitor, such as Alpelisib or Inavolisib. We see higher rates with those two agents, higher drug dosages, or concurrent use of a corticosteroid, like a systemic oral corticosteroid, if they're on that for some reason. Obviously, that can raise their glucose. And then longer durations of therapy. Some laboratory risk factors that we might be looking for at baseline would be an elevated fasting plasma glucose, a high hemoglobin A1C, or kind of in that pre-diabetes range, like nearing that 6% range. And then insulin resistance markers. These are things that more endocrinologists are looking at, but some of our patients, if we know they're at risk, we're going ahead and having that baseline assessment prior to starting. So looking at our different agents and hyperglycemia risk, let's kind of compare these quickly. So the incidents are all grade hyperglycemia. We see this higher pattern with our PI3 kinase inhibitors, more so than our AKT inhibitor, Capivasertib, or Gedatolisib, which is a dual PI3 mTOR inhibitor. We see much lower rates in these. With severity, we do see the highest grade hyperglycemia with alpelisib. We saw a high rate of hyperglycemia with inavolisib, but the severity was much lower. And then very low rates with capivasertib or gedatolisib as far as the severity goes. So our key pattern here, again, is just the severity is highest with alpelisib. What is the onset? So with our PI3 kinase inhibitors, we see a rapid onset of this hyperglycemia, so we're really catching this in the first week or two of therapy. With capivasertib and gedatolisib, we think we're seeing that a little bit later, but still probably in the first 1 to 2 months of taking this treatment. So key pattern is that PI3 kinase inhibitors have a little bit earlier rapid onset than others. So monitoring. Baseline, we want to have a fasting plasma glucose, a hemoglobin A1C at baseline, just to have that good baseline to compare it to later on. And then we can go ahead and risk stratify these patients. We know our patients are more at risk if they have pre-existing diabetes, obesity, or on a corticosteroid. And then monitoring. We go ahead and prepare the patient for this monitoring because they are going to be coming in much more frequently in that first cycle or two, and then it gets much easier on them. So they're going to have weekly monitoring of their glucose for the first 2 to 4 weeks, making sure they know that they need to come in fasting. Do not eat anything other than maybe black coffee before you come into the clinic. And then they'll have monitoring every 2 to 4 weeks. And obviously, if they have elevated glucose, they're going to come in more frequently for a little while. Hemoglobin and A1C, we'll check that every 3 months. And then what are some strategies to prevent and manage hyperglycemia in these patients? So as nurses, I know we're all taught that prevention is key. The better we can, tackle this on the front end, the better outcomes our patients will have. So at their first visit, when we know we're starting this treatment, really good education on lifestyle changes is really important for these patients. So talking about nutrition, emphasizing complex versus simple carbohydrates, less processed foods, lean proteins, healthy fat, fibers, physical activity, trying to aim for at least 30 minutes a day, at least 150 minutes a week, and then reducing their time sedentary. Weight management, so trying to maintain a healthier weight. Even a modest amount of weight loss really can impact a hemoglobin A1C when you're kind of following somebody throughout the months. And then self-monitoring, so kind of educating on glucose monitoring. This is probably going to be for patients that already were doing some at baseline, whether they're a diabetic or pre-diabetic, and going through that. And obviously, if they have hyperglycemia, they may start glucose monitoring at home, so kind of preparing them for that. And then looking at table 2 here in the bright blue. So, when would we start an anti-diabetic medication when we see hyperglycemia on these agents? So really that 126 milligrams per deciliter mark is when we would think about starting something in these patients with a fasting glucose. So at that point, we would start something and we'll go through kind of how to continue monitoring that. If they're over 160, we would want to enhance their anti-diabetic therapy. We're probably going to be thinking about holding treatment and getting them in with an endocrinologist at this point as well. Obviously, anybody with over 250, this is more severe hyperglycemia, we would be holding and getting them in with an endocrinologist and considering insulin at this point. Our first-line therapy for an anti-diabetic is going to be generally metformin. That would be contraindicated in somebody that has some renal insufficiency. So if they have a GFR greater than 30, this is appropriate. Otherwise, we may want to consider another agent. So generally, we are starting metformin. Metformin can contribute to diarrhea. So this is certainly something we want to consider in these patients that may already be having diarrhea concerns on this regimen. And then other agents we can add would be a GLT2 inhibitor, DPP4 inhibitor, a GLP1, or even insulin. Those patients are probably going to be involved with an endocrinologist if we have insulin on board. And then table 3, thinking about dose modifications. When do we dose reduce? When do we hold treatment? So for those patients that reach that over 160 range on their fasting glucose, we would want to consider a dose reduction and obviously optimizing their therapy. If they're over 250, we would want to hold treatment at this point, get their fasting glucose in much better range in less than 160, and then we can consider restarting at a reduced dose. So now let's go through a case. I'm going to move through this rather quickly, but this is essentially a 58-year-old female with hormone receptor positive metastatic breast cancer. She's a school art teacher. She lives in a suburban area. She's divorced with one adult daughter who's living out of state, so she has limited support at home. She's active in her local community theater group and designs costumes. She has a good creative identity, values independence, and she doesn't want to be a burden to her daughter, so she tends to underreport symptoms. She also relies heavily on comfort foods during periods of stress, and she is overweight as a result. So you can see her history here. Essentially, she now has metastatic disease. She's had a CDK4/6 AI combination and is now needing a new line of therapy. Her NGS liquid biopsy shows a PI3 kinase mutation, and so we're going to start Alpelisib with fulvestrant. So looking at her risk factors, she's overweight with a high BMI. She has sedentary periods during grading seasons at work. She does admit to stress-related eating, and we actually check her baseline lab values, and she does have a kind of a pre-diabetes picture with a hemoglobin A1C of 5.6 and a fasting glucose of 110. So about 3 weeks after initiating Alpelisib, she reports increased thirst, frequent urination, fatigue, all of these signs that can be consistent with hyperglycemia. She failed to report these immediately, waited about a week when they started just because she didn't want to burden anyone. We bring her in for a lab check and her glucose is 198. So we initiate metformin at 500 milligrams BID and discuss some lifestyle changes with her. And we lay out a clear plan to bring her in every week to monitor her glucose for now. At our 2-week follow-up, her fasting glucose is still elevated at 165. We don't want to increase the metformin anymore at this point because of the concern for diarrhea. So we add dapagliflozin at 5 milligrams once daily at this point, and go ahead and get an endocrinology consult on the books. At 3-week follow-up, she's improved to 125. We go ahead and start some home glucose monitoring to limit her visits into the clinic because she is a teacher and doesn't want to miss work. At her 4-week follow-up, her fasting glucose is elevated, but still much more stable. So we transition to a 2-week monitoring plan. And then at 6 weeks, she sees her endocrinologist. The visit goes well. She is feeling much more in control of her glucose and opens up to her daughter and the team about this. And she's able to continue working, participating in theater, and doing what she loves. So what are some of the key takeaways from this case? Alpelisib is associated with hyperglycemia. This is very common. We want to make sure we're doing that early, more frequent monitoring every week for the first 2 to 4 weeks. This is critical because we see it so early on. And then managing with a multidisciplinary team, so the oncologist, the APP, her triage nurse being informed, her nurse navigators, endocrinologist, and nutrition. And then remembering that our psychosocial factors for our patients can really influence symptom reporting and adherence. And treatment can often be continued successfully if we're able to proactively maintain their glucose.
Great. Yeah, great case that I think highlights many of the things we talked about for the drug, but I think puts it into a really helpful real-world clinical context. So thank you for sharing that. We're gonna keep moving on and add another drug to the mix here. Reva's going to tell us about Capivasertib, which is the first FDA-approved AKT inhibitor.
All right, so we'll switch gears and talk about AKT inhibition now. But before we do, we're starting to have the good problems to have in this space, right? So we're starting to have more drugs to select from. We're starting to think about how do we sequence those drugs. So let's spend a minute talking about sequencing a little bit because you've seen a few different trials now. And what started originally sort of in this space was patients get frontline endocrine therapy, CDK4/6 inhibition, and at the time of progression, second-line therapy, we do some sequencing, and if we find a PI3 kinase mutation, we switch the endocrine backbone, we add a PI3 kinase inhibitor, and that was sort of the approach. And now more and more we're starting to see studies that are looking at triplet approaches, so bringing the CDK4/6 and the PI3 kinase inhibitor together. So you heard about Inavolisib, which follows the second paradigm here. Patients start up front with endocrine therapy in the adjuvant setting, they progress, and so in the frontline setting, you're bringing in the triplet. You're adding the CDK4/6 and the PI3 kinase agent at the same time with a switch in endocrine treatment. And now we're starting to see a third wave of studies that's looking up front at all three agents. So we start off the bat in someone with metastatic disease with the endocrine agent, the PI3 kinase inhibitor, and the CDK4/6 inhibitor, and then we've got to figure out what we do downstream. So important to put that into context because you're hearing about different agents and different studies and different approaches, but for the purpose of the next few minutes, we're going to focus on that first approach, which is start with CDK4/6 and an AI, and then switch at the time of progression if we find a mutation to PI3 kinase inhibition plus a different endocrine therapy. So I'll blow through this section because you already heard about SOLAR-1, which was looking at Alpelisib. So this was the first of the agents that came out. This was an alpha-specific PI3 kinase inhibitor, so it was targeted, again, just to those patients with the PIK3CA mutation. And in those patients on the top right, you can see that there was a significant improvement in median progression-free survival in the second-line setting when Alpelisib was added to a switch in endocrine therapy. So this was exciting. It was the first time we saw an improvement with PI3 kinase inhibitors. But SOLAR-1, as you heard, the toxicity levels were very high. So over 75% of patients had grade 3 toxicities, which meant they were really sick from their side effects. And the most common were hyperglycemia, rash, diarrhea, which is pretty classic of these agents, as you've heard. And this led to a discontinuation of 25% of patients on study stopped Alpelisib because of these side effects. And so in the community, you can imagine that's going to be even higher because in a regulated study environment, a quarter of patients had to stop the agent. So it was very toxic. So since that time, there's been a quest to find less toxic, more efficacious agents that target this pathway. And that's where AKT inhibitors entered this space. So AKT, if you remember, is more downstream in the pathway. And so the hope was that it would be a little bit better tolerated. So Capitello 291 was a study that looked at the AKT inhibitor Capivasertib plus fulvestrant. So it was set up similar to SOLAR-1. It was for patients who were coming off of frontline therapy, went on to get second-line combination AKT inhibitor and fulvestrant. It did include all comers, but patients were evaluated for the presence of a PI3 kinase mutation. So here's the primary endpoint, median progression-free survival. So on the left in the overall patients, so in all patients on the study, there was an improvement in median progression-free survival. But specifically, what's of interest here on the right is that in those patients who had a mutation in the pathway, so either PIK3CA, AKT, or PTEN now, because you're more downstream, there was an improvement in median progression-free survival with a hazard ratio of 0.5. And important to look at key subgroups as they relate to our patients, right? So thinking about our patients in the second-line setting, so these are patients who've progressed on CDK4/6. Many of them have visceral metastases like liver mets. Most of them have had prior CDK4/6 inhibition. Some of them may have gotten prior chemotherapy even in the interim if they had aggressive disease. And when we looked across those subsets, there was a consistent benefit of adding the AKT inhibitor Capivasertib. So it's really relevant to the patients that we treat in the clinic. So I know we've talked a lot about safety, but here is the overall safety from the Capitello study. Pink is grade 1. Darker pink is grade 2, and then purple is grade 3. So you can see there was a relatively high incidence of diarrhea, rash, as we expect from these agents, but primarily the events were now grade 1, grade 2, and we had a lower incidence of grade 3 events. So a little bit better in terms of tolerance. The hyperglycemia events were lower with Capivasertib, so about 18% of patients on this study. So this led to overall lower rates of discontinuation, compared to the SOLAR-1 study. So approximately 10% of patients now discontinued Capivasertib or placebo on study. So here's the two studies side by side, Capitello 291 and SOLAR-1, both of which look at patients who progress on CDK4/6, and you bring in the PI3 kinase inhibitor with a switch in endocrine therapy in the second-line setting. They were a little bit different because SOLAR-1 was done earlier. None of the patients, or very few of the patients, had gotten CDK4/6 inhibitors in the frontline setting, versus Capitello 291, much more contemporary, much more relevant to our patients. 70% had gotten CDK4/6 inhibitors in the frontline setting. So for that reason, I don't want you to focus as much on the difference in numbers between these two studies, but what's really important is that there was a similar magnitude of improvement in median progression-free survival when these agents were brought into the second-line setting, and the hazard ratios demonstrated a statistically significant improvement when we targeted the pathway in the second-line setting. So with that data, similar to Inavolisib, we were sort of moving into earlier and earlier lines. Capitello 292 is now looking at the triplet regimen of Capivasertib, CDK4/6 inhibition, and fulvestrant in patients who have already received an AI, either in the adjuvant or the frontline setting. So more and more approaches looking at that triplet approach of bringing the CDK4/6 and the PI3 kinase agent together.
Great, thank you. We're going to just spend a couple minutes on the discussion here because I think with the data that you just shared, we had a radical shift in the way we think about treating these patients. So let me just ask you, in your practice, do you feel that you're prioritizing Capivasertib over Alpelisib for all patients in that second-line setting, or are there specific examples where you might still go with the original PI3K?
Yeah, that's a really important question. I mean, there's really two things we're weighing here. It's efficacy and toxicity, right? So toxicity with Alpelisib was quite high. 25% of patients had to stop treatment on study because of the toxicity. So with toxicity, Capivasertib has been much easier to manage in the clinic, particularly with hyperglycemia. And as you heard with rash, having some type of prophylactic management of that rash with antihistamines has really helped us in the clinic. And then there's the efficacy part. Generally, both of these agents are efficacious. They improve median progression-free survival, but they target the pathway at different points, right? So Alpelisib is a PI3 kinase inhibitor. It targets the PIK3CA mutation at the target, whereas Capivasertib is an AKT inhibitor. It's more downstream. And the question really is, in someone who has a PIK3CA mutation, has an upstream mutation, is it more efficacious to use the on-target drug or to use the more downstream drug? And this is debated, and we haven't had head-to-head comparisons, so we don't know. But that's why a lot of the newer drugs in this field are really trying to go back to the PI3 kinase inhibition and look at either mutant-specific inhibitors or alpha-specific inhibitors, trying to make them, more specific to the tumor, but still an on-target effect.
And Kelly, in your practice, are you seeing that too? Have you seen either a majority or a complete shift to Capivasertib?
I honestly would say it's been more of a complete shift to Capivasertib. I think that we're seeing that patients are tolerating Capivasertib a lot better than Alpelisib. We were seeing a lot more hyperglycemia with Alpelisib, rash, diarrhea. So I do think that, it's safe to say that this is the trend that we're heading towards with the Capivasertib.
Yeah, and I agree, and I sort of wonder how much of it is actually the drugs, right? And the drugs are better with just a broader therapeutic index, or like I'd alluded to earlier, we've just gotten, if you ran SOLAR-1 today, knowing what we know, what would the high grade and the discontinuation rates be with all the supportive maneuvers that you're teaching us about tonight? And I think the point Reva brought up about hitting the target directly versus downstream is an interesting philosophic question that the pendulum may swing back in that direction with some of these newer drugs. And Reva, to that point, can you Can you combine Capiva with other endocrine agents, or are you only using it with fulvestrant?
So today, the data that we have, the approval that we have is the combination with fulvestrant, so that's been my general approach. But as much development as we're seeing in the PI3 kinase space, we're seeing in the endocrine space. So we have SERDs and newer endocrine agents that are entering the space, and we're going to want to do new combinations, and so this is an active area of research. We're awaiting data from several of these SERDs and combinations, and so I think as some of this data starts to come out, I'm certainly going to start pushing the limits and seeing what I can combine.
And Melissa, one last question before we go back to some of the content. Thinking about what we talked about earlier broadly for the tox profile, in your real clinical practice, what are you telling these patients? Because you actually probably have more patients going on this than you do on Inavolisib, just given the size of the population. So when you're counseling these patients, what are you warning them about? What tools are you giving them? Kind of what's the threshold to call?
So Capivasertib, we do see more diarrhea than any of the other agents in this pathway. So diarrhea is certainly what we educate on a lot, starting loperamide or having it at home to start as soon as that first episode of diarrhea occurs. We do see a fair amount of rash, so I usually still have my patients start a non-drowsy antihistamine at baseline, make sure they're using good moisturizers. And then I think the other thing that's not necessarily a tox concern, but something that we really have to think about with Capivasertib is the dosing schedule. And so it's a little more unique than the other agents in that it's a 4 days on, 3 days off schedule, and it's also BID dosing. So any patient that we're concerned about oral adherence or elderly patients that have trouble keeping track of all their medications, really kind of giving them a dosing diary and going through that in advance, I think is key with this agent.
Great. Thank you. Okay, we're going to turn back to practical management of some of these toxicities. Kelly is going to teach us about GI adverse events with this class of drugs.
Okay, so we'll segue right in. So this is just a little table reflecting just the rates of the GI issues that we tend to see with all of these agents. Like everybody on this panel has pointed out, with Capivasertib, the rates of diarrhea seem to be higher at 72%. But as Reva had mentioned earlier, really those are grade 1 and 2, and generally these events occurred earlier on in treatment, and they were associated with lower rates of dose reductions and discontinuations. So strategies that we use to mitigate and manage treatment-related effects, specifically with diarrhea. Loperamide tends to be everybody's best friend, so I always make sure that patients have this in their medicine cabinet at home. Sometimes if the loperamide isn't working and it's not really helping with the diarrhea, sometimes we will prescribe a diphenoxylate hydrochloride with atropine sulfate, and that can be just another tool in the toolbox to help to manage diarrhea. Also, obviously, it's very important for patients to stay hydrated and make sure they're drinking plenty of water, at least 8 to 10 cups a day. And I always tell people anything that melts is considered to be a liquid. So popsicles, Pedialyte, Jell-O, Italian ice, all of that counts, so it's really important. And then, of course, we have to do some nutritional counseling, and we want them to modify their diets as needed. Patients tend to not be in the mood to drink any alcohol, so we do tell them to limit their alcohol intake and caffeine intake as much as possible, as well as avoiding spicy foods, and they may want to lay off of, the ice cream and lactose-containing foods. We always encourage our patients to please call us if they're having, significant amount of diarrhea throughout a day. I'm talking like any more than 3 or 4 episodes, because we also want to make sure that they're coming into clinic if needed, just so they can get some additional support with IV hydration. We may check a complete metabolic panel just to make sure their electrolytes aren't out of whack, and of course we can certainly replace electrolytes in clinic as needed. So. Specifically related to nausea, vomiting, I always make sure that patients go home with a prescription for ondansetron and prochlorperazine, just so they can take that if they're nauseous at home. I tend to say to people that if they're going to be having diarrhea and they're nauseous, it's probably not a bad idea to start out with ondansetron because it can be a little bit constipating. So it's kind of like a twofer. It might help with your nausea, but it also can help a little bit with the diarrhea. So that's usually what I tell patients. Prochlorperazine can also be a tad bit sedating, so I tend to say if you're going to take that for the first time, you might want to take it in the evening before you go to bed, just so you're not zonked out during the day. And obviously, we've already talked about increasing fluid intake and avoiding like spicy foods, caffeine, and alcohol. With respect to stomatitis and oral sores, education is big with this because we certainly don't want patients to have painful oral sores where it's affecting their ability to eat or drink. I always tell people I'm not so much concerned with if you're not eating a lot of food, it's actually more about the hydration. So I don't want you to be not able to drink fluids because of these oral sores. So usually we counsel patients to just do some good old-fashioned warm salt water with a 1/4 teaspoon of baking soda. It tends to help coat the mouth a little bit better and just provide a little additional relief. We want to avoid any mouthwashes that contain alcohol just because that can be a little bit harsh to the mucosa. Good oral hygiene is crucial, so making sure patients are brushing their teeth twice a day, with a non-whitening toothpaste, I tend to say, and also flossing the teeth is important and keeping your lips well hydrated. I think that Melissa mentioned earlier in the program, but we usually send patients home with a prescription for dexamethasone mouth rinse. It's a steroid mouthwash. Specifically with Inavolisib, we tend to tell patients to do this more prophylactically, just to help to prevent oral sores. So usually we tell patients to swish for about a minute, 2 minutes if you can. It sounds like forever, but it actually helps just the dexamethasone absorb a little bit better into the oral mucosa. So usually we send patients home with that prescription. We can also send, a lidocaine-containing mouthwash if it's very painful. It kind of just helps to numb the mouth, and it can help patients with their oral intake. And then as far as with nutritional counseling, we've already kind of touched upon this, but, nutritionists are great referrals. We have a great group of dietitians where we are, so we always value their input. A lot of these agents will cause hyperglycemia, as you've all have heard. So we want to counsel patients on kind of limiting their simple carbs in their diet. So avoiding the white breads, white pastas, focusing more on complex carbohydrates. That's a good tip. And also avoid sweetened beverages and juices, following more of a Mediterranean diet, and eating smaller, more frequent meals or snacks during the day. That can especially help when patients are a bit nauseous. Just eating smaller bits during the day can be helpful. And everybody knows about the brat diet, so if you're having diarrhea, then just follow more of a bland diet and get your bananas, rice, applesauce, and toast. That's a good one. And then this is just a case, it's a 63-year-old female who has a hormone-positive metastatic breast cancer. Just to give a little bit of background about her, she's married and she has 2 adult children, 4 grandchildren. She was a homemaker throughout her life, and the biggest part of her life is her children and her grandchildren. So she takes care of and babysits her grandkids throughout the week. So the biggest thing for her is give me a medication that's not going to be toxic and not going to make me be in the bathroom all day because I have little babies to babysit. So it's always a conversation that we have. She was originally diagnosed with breast cancer in 2000. She received AC chemotherapy. She also had radiation. She took tamoxifen for 5 years. She had a metastatic recurrence in 2022, so 22 years later, she developed a hormone-positive metastatic breast cancer, bone only. We started her on palbociclib, letrozole, and zoledronic acid at that time. Unfortunately, about 6 months into the course of her first-line therapy for her metastatic diagnosis, she actually was hospitalized with neutropenic sepsis and cholecystitis. She had a stent placed. she was miserable. So we, of course, held her palbociclib. When she was out of the hospital, we were able to resume it at a dose reduction, and she did very well on that for about 6 months, and then we switched her to fulvestrant palbo just because she had some progression in her bones. She did well on that regimen for 3 years and then was found to have, again, progressive disease in the bones. So we did some genomic testing, and she had a PIK3CA mutation, so we started her on Capivasertib and fulvestrant. We did start her at a dose reduction of 320 milligrams BID, 4 on, 3 off, just because of tolerability concerns. It actually took us about a month to get her started just because she was so anxious about the side effects. And luckily, she's done very well. She's just had intermittent diarrhea, so she uses the loperamide as needed. And I just wanted to show a quick picture of her tumor markers, how they've been looking. So you can just see they were rising from November to March, and then March is when we started her Capivasertib fulvestrant. And you can see like her tumor markers have actually almost decreased by half just within like a 1 month, 6 week period of being on this targeted therapy. So I think it's working for her.
Great. Yeah, thank you for sharing the case. Striking decline on the tumor markers, which looks good. Okay, we're going to keep going right through here, and Melissa's going to tell us about management of dermatologic adverse events with these drugs.
Okay, let's jump right in. So the most frequent dermatologic AEs that we see with the PI3 AKT mTOR pathway is a maculopapular rash. We can also see pruritus and dry skin. Looking at our different agents here, we do see a good bit of rash with alpelisib. More common to see a higher grade rash with this agent, but in SOLAR-1 they did add prophylactic antihistamines and saw a dramatic reduction in those high grade rashes with this. So you see a wide range there of 2 to 20% depending on their prophylaxis that they used. With Capivasertib, about 35% of rash, lower grades of high grade rash. And then Inavolisib, 25% of patients, more rare in that high grade, as well as Seth has said. Some of this is probably just us doing so much better at managing these AEs as we've gone on. And then Gedatolisib, which we'll talk about soon, is a new agent that will be coming that's a dual PI3 mTOR inhibitor. And we can see a rash occur with this one about the same rate, and about 27% or so of patients, but rare to see high-grade rash with this one as well. So what is the role of prophylactic antihistamines? I know we've mentioned it several times as we've gone through. The rationale for an antihistamine is that dermatologic AEs are so common with all of these agents, and they usually have an early onset of rash within about the first 2 to 4 weeks of treatment. This is likely mediated by immune and inflammatory pathways with histamine release and cytokine release occurring. So antihistamines can help reduce the itching as well as the rash severity for these patients, help them have more quality of life and a more durable benefit on these treatments. So our strongest data with using antihistamines was in SOLAR-1 trial with alpelisib. So adding in prophylactic antihistamines reduced the risk of all grade rash by actually half. And we actually saw a reduction in that high-grade rash by 40%, and the patients did not have as many treatment interruptions. So really impactful for rash. The recommended approach is actually to start that prophylactic antihistamine on day 1 of their therapy, continue it for about the first 2 months or so, which is their highest risk period for developing a rash, and then you can continue it longer or even keep it on for their entirety of their treatment if they're not having any negative effects of the antihistamine, which normally we would not see. We want to recommend non-sedating antihistamines for these patients who already are battling fatigue. So fexofenadine, cetirizine, or loratadine are great choices, and they just have to take those once a day, so very simple. Some topical management of dermatologic AEs. We want to honestly start all of our patients with an emollient even before they've developed a rash. Just really good skin care, hydration of the skin can reduce rash and reduce severity. So starting that at treatment initiation, using a thick cream or ointment, specifically a ceramide-based is preferred, and this really improves their outcomes and supports their skin barrier integrity. Topical corticosteroids is what we would use as our first treatment at the first sign of a rash. So most of the time we're going to be using a low to moderate potency topical corticosteroid, such as hydrocortisone cream, which is over the counter, or a triamcinolone cream. We can actually prescribe that in a larger kind of a tub so they can really lather it on really well. We want to avoid those high-potency corticosteroids, particularly to the face and intertriginous areas. And we can see decreased inflammation, decreased erythema, and decreased progression to that higher-grade rash when we're using these topical corticosteroids appropriately. Another option we can use if we have rash is a topical antibiotic. This would be if we see signs of secondary infection, maybe they're scratching a lot and they have impaired skin integrity, and we see some crusting, some pustules, some oozing occur. This would be we would consider also adding in a topical mupirocin or clindamycin as well. We move on to systemic or oral corticosteroids for these higher grade rashes when we see this moving on to that grade 3 severity. We're also going to hold their therapy at this point and probably refer to dermatology. We want to avoid these systemic corticosteroids if we can, because we know they can increase their glucose and they're already potentially battling hyperglycemia. So the more we can kind of catch these skin changes on the front end, the better. So looking just at kind of the grading of our rash and what we would do with each grade. So if we see somebody come in with a mild rash, a grade 1 rash, these are localized symptoms. It probably affects less than 10% of their body surface area. We would continue their PI3 AKT mTOR inhibitor and make sure they're using a good emollient. Go ahead and add on a topical corticosteroid. And we don't necessarily need to dose modify yet if it's just that low-grade mild rash. If it moves on to grade 2 and it's more diffuse, we would potentially do a moderate high-potency topical, make sure they're taking an oral antihistamine. This is the point that we would consider interrupting their therapy, letting this resolve to grade 1, and then we can decide if we want to resume at the same dose or potentially reduce the dose. If they have a grade 3 rash, we're for sure going to stop therapy, hold therapy until this improves to grade 1. Again, these are the patients we're going to consider sending to a dermatologist and maybe even adding a systemic corticosteroid on top of what they're already doing with a more high-potency topical. Grade 4 life-threatening rash, such as Stevens-Johnson's, those would be patients that we would permanently discontinue therapy and they would be hospitalized until improvement. So a case, we'll look at a patient on Capivasertib. This is a 42-year-old female with metastatic hormone receptor positive breast cancer. She's a single parent with limited support. She has an hourly paid job, so we really don't want her to miss work if possible. She does have ongoing body image concerns that was triggered by alopecia that she had in adjuvant therapy. She lives far from our clinic. So she now has progressed on first-line CDK4/6 inhibitor. She does have a PTEN mutation. And so we're going to choose Capivasertib because this is an AKT inhibitor. It works for PTEN mutations as well, combination with fulvestrant. So week 3 of therapy, she calls in reporting a diffuse itchy rash to her trunk and arms. It's disrupting her sleep because of the itching. We bring her in. We see this maculopapular rash, which is grade 2. We go ahead and add those medium to high-potency topical corticosteroid because it's a little bit more advanced rash at this point. Make sure she's using a good emollient cream. Make sure she's taking a non-sedating antihistamine. And then ensure she's scheduled to come back in a week or so for her next visit for her fulvestrant injection to reassess this rash. She comes in at week 4. It's a persistent rash. It really hasn't improved. It's more symptomatic, more itching. She's concerned about her appearance and her sleep, of course. So we go ahead and interrupt her treatment with Capivasertib. We start a short course of oral steroids, continue her topical therapy and antihistamines, add diphenhydramine at night to help with sleep and itching at night. And then we actually arrange a telehealth visit to see her next because she does not want to miss work. And she lives far away from the clinic. So at week 5, we see her via telehealth. We're able to assess her rash on our computer, and it's improved to grade 1. She's in a much better place here. We go ahead and restart her Capivasertib by the dose reduction, continue the topical steroids and the emollient cream, and obviously the antihistamines. And then at week 6 update, it's still mild, slowly improving. She's much happier. She's sleeping better. She's so grateful to have not missed work. So this just shows you that if we can manage these rashes promptly, quickly, hold treatment when we need to, we can really help these patients be on a more durable therapy and have good quality of life and maintain their life and their schedule.
Great. Thank you for sharing. I think that case really demonstrates the right way to get in front of it and try to help with these symptoms before they become too limiting. So let's keep going. We're going to turn our attention now to the newest agent on the block, which we were joking earlier. I think it's my New York accent. It's not Gedatolisib, it's Gedatolisib, like Jedi. Potential role of Gedatolisib in the management of hormone receptor positive metastatic breast cancer. Very, very exciting drug. Just to bring you back to what we were speaking about earlier, remember that the PI3 kinase pathway starts at the top of the cell. You have these external signals that turn on these receptors. PI3 kinase activates AKT, which activates mTOR, and mTOR and AKT drive all of these bad things that the cancer cell needs. What's unique about the Gedatolisib is that it actually blocks the entire pathway. So it blocks PI3K, AKT, and mTOR, as opposed to all of the other drugs that we've been talking about, which only hit in one area. Now, of course, there's a bit of a trade-off here. Because it covers the entire pathway, it's not safe to give a drug like this orally. The toxicity is too high. So this drug is actually given IV, 3 weeks on, 1 week off. And that's different than all of the other agents that we've been discussing so far this afternoon. Here's part of the phase 1 study that we just published a few months ago in 2025. This was a subset of the phase 1 study where we were looking at the Geda in 41 patients in the frontline metastatic setting. So we've been talking about moving these drugs earlier as doublets and triplets. So here these patients were treatment naive, hormone receptor positive, metastatic. Not all of them were PIK3CA mutant, about 22%. And look, you can see here, look at that progression-free survival curve, shifted up and to the right, including overall survival. The median progression-free survival here was 48 months. Now again, this is the frontline setting, but still, that's very, very impressive, right? Multiple years, these patients are staying on this drug, having good control. Overall survival, almost 80 months. And response rate, so the response rate, meaning how many patients actually had shrinkage of their tumors, reduction on that waterfall plot on the bottom. Remember, every time the line drops below the dotted line, that shrinkage of the tumor was almost 80%. So almost 80% of these frontline patients had a response, and that response was durable with excellent progression-free and overall survival. So this led to the Victoria-1 study. This is a big prospective phase 3 effort. These patients had 1 to 2 prior lines of endocrine therapy. Everybody had a prior CDK4/6 inhibitor, no prior chemotherapy, none of the prior agents we've been talking about tonight, PI3K, AKT, or mTOR inhibitors. Just like the SOLAR-1 study, this study was divided between a PIK3CA wild type and a PIK3CA mutant cohort. So far, the only data that we've seen presented has been the wild type cohort. So these patients were randomized 1 to 1 to 1, fulvestrant alone, fulvestrant Geda doublet, or triplet, fulvestrant, palbo, Geda. And remember, this is really the second line, primarily, metastatic setting. And here are the curves for the doublet. So this is fulvestrant alone versus fulvestrant plus Gedatolisib. And again, you can see a really significant shift between those curves. This translated to an improvement in median progression-free survival from 2 to 7.4 months. So really, really significant change, highly statistically significant. And then here's the triplet, which looks even better, from 2 to 9.3 months. And I would highlight that this data is even more impressive because this is the PIK3CA wild type group. None of these patients have PIK3CA mutations. And you're using a PI3K, AKT, mTOR inhibitor. So this is some of the first data in the modern era that we've seen after progression on a CDK4/6 inhibitor without selecting for ESR1, without selecting for PI3 kinase, getting us up over that 6 month into the 9 to 10 month range, which is moving in the right direction. And then here's the toxicity table. Now, in the middle, in orange, you have the doublet, and in purple, you have the triplet. And again, here we're seeing a trend toward less overall high-grade toxicity. We have the lowest rates of hyperglycemia here. Look at the grade 3 toxicity with the triplet is only about 2 to 3% hyperglycemia, dramatically reduced, for example, compared to alpelisib. And what's also striking to me is when you look at the rates in the doublet and the triplet, they're not that much different. I mean, we see more cytopenia and things related to the palbociclib, but we don't see a lot of additional toxicity related to the Geda, which is good. The trade-off may be a bit more stomatitis here, mostly low-grade, about a 70% low-grade stomatitis rate, but about a 15 to 20% high-grade stomatitis with the triplet. And here's that table that I showed you earlier, but now we've plugged in the right-hand side of it. So we've reviewed all the data for all of these studies: alpelisib, Inavolisib, PI3K inhibitors, Capivasertib, AKT inhibitor, Gedatolisib, PAM, PI3K, AKT, mTOR inhibitor. And remember, in gray, I'm showing you the winner, meaning the lowest rates of toxicity across the class. And you can see the Geda actually had the lowest rates of hyperglycemia and diarrhea. Capivasertib had the lowest rate of mucositis, stomatitis, and Inavolisib had the lowest rate of rash. So as we move forward in time, we're making these drugs more tolerable. Also very impressive, the Geda data here is triplet. It's actually triplet data, and we're still achieving the lowest rates with 2 out of 3, the trade-off being the IV formulation. And so remember, there's a second half of the study. The bottom half of the study is PIK3CA mutant. We haven't seen the data, but we have a press release. This came out just a few days ago as I was finishing the slides. So the press release here stated that it met its endpoint. So the primary analysis of Geda combined with fulvestrant and palbociclib demonstrated statistically and clinically meaningful benefit in the PI3K mutant population. We don't have the numbers yet. We haven't seen the curves yet, but they're going to present this at ASCO in a few weeks. This will be an oral session on June 2nd, so I'm sure we'll have a chance to reconvene at a future date and put up a few extra slides and show you the results from the second half of the study. So where does that leave us? And I always joke with Neil when we give these talks, every 3 or 4 weeks I have to change this slide because we have so many new FDA approvals. This is what I think the landscape looks like today. Most patients in the frontline setting are getting an AI with a CDK inhibitor, typically ribociclib. We talked a lot today about that endocrine refractory PIK3CA mutant population. They're getting the triplet with Inavolisib. In the second line, after they progress, this is where we've really entered the era of personalized and precision medicine. If they have ESR1 mutations, which you guys will hear about in a subsequent lecture, I think, during this series, they could get elacestrant, imlunestrant, vepdegestrant. These are new anti-estrogen drugs. We talked a lot today about the PIK3CA mutant and the AKT and PTEN. They could get alpelisib or capivasertib with fulvestrant. If they're BRCA mutant, they could get olaparib or a PARP inhibitor. If they're none of the above, this is a big area of unmet need. Fulvestrant alone, fulvestrant with more CDK, everolimus that we talked a little bit about today. And once they've exhausted all of these endocrine options, that's when we're using antibody-drug conjugates like trastuzumab deruxtecan, chemotherapy, sacituzumab, Dato-DXd. Now I'm showing you phase 3 data where we don't yet have an FDA approval in italics. So we have the SERENA-6 study. We're waiting for an FDA decision on that. You'll hear more about that in a subsequent lecture, I think later this weekend. We have data that we talked about today for everolimus and for Gedatolisib. And again, we need to see what are the biomarkers going to look like. If and when they get approved, will the FDA say you have to have ESR1 for everolimus and giredestrant? Will the FDA say you don't need any biomarker for Gedatolisib, which would be a huge help for these patients in that biomarker agnostic group? And there's lots of new drugs coming online: KAT6 inhibitors, new CDK inhibitors, new PI3K RAS inhibitors, new antibody drug conjugates. So I'm going to have to change my font and break this into, I think, 2 slides probably pretty soon by 2027. Okay, so this is, I think, one of our last discussion slides. Let me start with Reva. In what line of therapy do you think you're going to start to use the Geda combos? And how are you going to decide potentially in terms of PIK3CA status? I know you don't have the data yet, but you have the press release and we have the wild type data. How's it going to enter your clinical practice?
I mean, I think in the wild type space, it's particularly exciting, right? Because we, as you mentioned, Seth, we really haven't seen those numbers in median progression-free survival in the wild type space. We have very limited options. We know that combinations, patients do better. If we can bring in something targeted towards their tumor, patients do better. But for those patients that don't have a PI3 kinase pathway mutation, they don't have an ESR1 mutation, we're left with very little. And so to see this improvement in those wild-type patients with this drug that targets this pathway really tells us there's more to this pathway. It's not just the mutations. It's probably being activated in other ways. And it's exciting to have this option for our wild-type patients. In the mutant patients, it's a little hard to say until we see the data. It's a little bit more of a crowded space. We have a lot of other options. The IV formulation is going to be a little bit hard for patients, particularly because it is weekly for several weeks. And so I think we just have to see what the data looks like, see how the IV formulation goes and how patients take it. I think it's going to be very patient dependent, who's open to it versus not. So hard to tell. Ask me at a future session.
Thank you. Kelly, I'm curious, and I'm not sure if you've had personal experience with this drug in the context of the clinical trials at Dana-Farber, but just looking at the data that we're seeing now, do you have a sense of maybe what kind of patients might be better or worse for doublet or triplet? And I think baked into this consideration is, what are your thoughts on the IV aspect of it? Do you think that that's a big barrier for patients who may or may not be interested in this?
Yeah, I have to say, I haven't had personal experience with the Gedatolisib yet in clinical practice. I do think like a big factor is the IV formulation of this drug, because whenever we think of hormone-positive metastatic breast cancer, and I always say this to patients, we have so many great oral therapies that it might be a little tricky integrating like an IV therapy into the mix. So I think, for patients hearing and seeing that, it may be a bit challenging, but at the same time, very exciting. And I'm looking for more to come on that.
Great, thanks. And just to keep us on time really quickly, Melissa, the last question here, as you think about this coming into clinical practice with maybe a future FDA approval, do you have any sense of big picture what kind of counseling or education differences there might be? Obviously the IV piece, but in terms of the tox.
Outside of the IV piece, I think with the tox, we do see more stomatitis with this than the other agents, and we can see high-grade stomatitis. So in this trial, they actually utilized the dexamethasone rinse as prophylaxis. So teaching patients how to use that when they come in, they're going to start this probably on day one. They take it 4 times a day. They're going to want to swish this for 1 to 2 minutes, keep it in their mouth as long as they can, and then spit it out. But we actually also want them to do that an hour before eating and drinking. So I usually tell my patients with the Dex rinse to do it after breakfast, lunch, dinner, and at bedtime. If they're doing it after a meal, they should be okay to not eat or drink for an hour or so. And that helps them stay on track with using that Dex rinse. So outside of the other stomatitis prevention and management strategies we talked about, just kind of educating on how to use that rinse with this agent.
Great, thank you. Okay, time flies. We're on to our last topic here. Back to Kelly to teach us about managing cytopenia in this population.
Okay, so I'm going to take it home quickly for us here. So I think we've already talked about this slide, so I'm not going to go too far into it, but I think the key thing just to mention is that you can see that the higher percentages of neutropenia with the Inavolisib and the Gedatolisib, and have to remember that these are usually paired with a palbociclib, so that can, I think, hyperinflate these numbers a bit, just higher rates of neutropenia goes. So as far as with monitoring, we definitely need to talk and educate patients about that they will have to be coming to clinic a little bit more frequently initially when they start these medications. So usually we actually start by labs at least once weekly for the first 4 weeks that they're on these medications, and then we'll space it out to every couple of weeks for the next 8 weeks, and then monthly thereafter are clinically indicated. I think a good point to make, and I think we have to remember about geographically, where are you? In Boston, we're like in a city type of setting, so it's usually not so challenging for patients to come to clinic this frequently to get their labs monitored, but maybe in a more rural setting, it may be more challenging. So we even allow patients to go to their local lab, to just get the labs monitored a little bit closer to home. So it is definitely more intensive when they first start these types of therapies. As far as with the grading and dose modification or treatment interruption with Inavolisib specifically, this drug, it comes in 3 dose forms. So, it can be taken 9 milligrams once daily, it can be taken 6 milligrams once daily, or 3 milligrams once daily. The little patient education piece is that it only comes in 9 milligram and 3 milligram tablets. So if they're going to have to dose reduce to 6, you just need to make sure that they know to take 2 3 milligram tablets at once. As far as with grade 4, usually we have patients hold the drug until they recover to less than or equal to a grade 2. We can resume it at the same dose, but we tend to dose reduce 1 dose level. In other grades, there's none required, but of course you can drop it down 1 dose level. As far as with Capivasertib goes, I think that Melissa already mentioned this, but it does come in 400 milligram BID dosing. It's taken 4 days on, 3 days off. You can also drop it down to 320 milligrams and then 200 milligrams again twice daily for 4 days on and 3 days off. With any grade 4, you want to permanently discontinue the medication. As far as with grades 2 and 3, usually with a grade 2, you would want to hold the Capivasertib until they recover to at least a grade 1 or less, and then you can resume it at the same dose. If that recovery is going to take them longer than a month, then usually we're going to resume the Capivasertib at 1 dose level lower. As far as with, supportive care strategies to help manage cytopenias in patients who are taking these medications, usually the first step in managing cytopenias is to actually just pause therapy, hold it for about a week, and then recheck labs and modify the dose if needed. Usually we don't have any space for growth factor support like filgrastim, just because these are oral therapies, so we tend not to use filgrastim. And certainly you can consider, supportive transfusions if needed, if they're anemic or thrombocytopenic. But again, we tend not to do this. We just tend to hold the drug for a week and then repeat labs and see how they're doing. So I wanted to spend a little time on this case. So this is a 54-year-old female. She has hormone positive, HER2 negative metastatic breast cancer. Just to give a little bit of background about her, she's married. She has 2 daughters. They're 26 and 33. Her oldest daughter is currently pregnant and expecting a baby girl in June, so that is the topic of conversation at every visit. She just had a baby shower last month. So obviously, just to mention, as nurses, we always want to think about, what's your why? What's so important that we have to keep going, keep continuing? And as long as you are able to figure out their why, I think it does help, care for them more thoughtfully in the long term. So she was originally diagnosed with breast cancer in 2023. She had a mastectomy. She received AKT chemotherapy. Taxol was dose reduced for neuropathy. And then she also got post-mastectomy radiation therapy. She started anastrozole and then switched to exemestane in 2024. In 2025, she started to develop some left groin pain, so we got a PET scan, and that showed she actually had pretty diffuse bony metastatic disease. She had a fairly large, almost 10-centimeter lesion in her left iliac bone, and she had a non-displaced pathologic fracture. So she was having quite a bit of pain from that. She received palliative radiation, and then she was started on fulvestrant with palbociclib, and she also got monthly denosumab because of the bony metastatic disease. At the time, we had also done genomic testing, and she was found to have a PIK3CA mutation, so we added on Inavolisib to her regimen about a month after she started on the fulvestrant and the palbo. She was actually hospitalized just a month into this regimen. She had pretty severe hyperglycemia. Her blood sugar was actually greater than 600. So the Inavo was held for several weeks. Endocrinology was definitely involved at the time. And then she was discharged from the hospital. She then had another pathologic fracture in her C-spine, so she had to receive radiation therapy to that lesion as well. Obviously, her therapies were held during radiation. I just want to make a note that we did resume the Inavolisib at a dose reduction, and her palbo also has been dose reduced. So this is kind of the meat of it, and I apologize that this is very small, but I think it's a great case just to highlight cytopenias with the Inavolisib. I think that just a note to make about patients who have bony metastatic disease, especially with her, it's so diffuse, is that we always have to consider like how much of this is just diffuse bony involvement, has the disease infiltrated your bone marrow, which is what's causing these cytopenias, or is it drug-related? In this sense, I think it's a combination of both for sure. So over the period of time, we had to definitely have her come to clinic a lot more frequently for lab checks. You can see she was quite thrombocytopenic, anemic, and neutropenic. After December is kind of where she started to level out with her blood counts, and she's actually still doing very well on Inavolisib at a 3 milligram daily dose, and her palbo's at 100 milligrams. So she's doing very well. And then one last point just to make with cytopenias is that we always have to remember this patient received doxorubicin a few years back. There's always a rare risk of secondary leukemias with doxorubicin, so just something to keep in the back of your mind. But of course, on her CBC, we do a peripheral smear, and she's never had blasts. So just something to keep in mind.
Great, thanks so much. So thanks to you all for joining us. It's impossible for me to live up to our host, Neil Love, but I want to thank the team at Research to Practice, and thanks to all of our panelists. So thanks again, appreciate it.